I'm Hugh Herzig. I'm the consultant psychiatrist with the regional NHS service for adults with eating disorders. It's called STEPS, and it's based at Southmead Hospital and covers the NSSG and also Baines. And I want to talk to you really about why we think that the HIT model is so helpful and so appropriate to our particular clinical area and where we've got to so far. We're very new. We were approved as a HIT in early this year, and we've sort of come on stream just a couple of months ago, so we're sort of puzzled quite by what that means now that we're a HIT, but that's very exciting to be here. A year ago we were here really puzzled, and now we're here as a HIT, so that's great. The directors of the EdHIT are myself, Helen Molsom, who's an academic at UWE, she's an associate professor of social psychology, and also Grace Elias, who's a commissioner in Bristol CCG. Our client group, the people we work with, are always falling between services. There's different reasons for that. I'll say a bit about that. And that's essentially been the experience that we have and that they have especially. And that's when risks happen as well. Anorexia nervosa, which is one of the forms of eating disorders that the extremely severe form, has a high mortality rate, the highest mortality rate of any mental illness. So people tend, that's a time when deaths happen, when people are transitioning or failing to transition adequately between services. So I'm going to say a bit about the sort of reasons why care gets fragmented and inconsistent for the people we're trying to be helpful to. People get very medically unwell with an eating disorder and need to be in medical hospitals at times. Those admissions are often chaotic and unhelpful and poorly managed. The medical teams don't know what to do or for how long to do it. They are not used to working with patients who are highly ambivalent about having treatment. So all those questions don't really get addressed unless you carefully plan and support a medical ward to provide joined up services. So our NHS service tries to outreach into medical wards facing that, and indeed we try to sort of anticipate and plan those admissions when they happen. So that's one example of a transition that it needs careful management, is often not well done. Similarly, the people we work with are going to GPs who may not know much about eating disorders. Anorexia nervosa is not a common illness, although probably becoming more common. The care pathway may be a referral to a local mental health team. It may be that team would have access to a tertiary service like our service, or maybe not, because some areas don't have a tertiary eating disorder specialist service. So there's quite a lot of opportunities for patients to disappear out of the system, especially if they're ambivalent and wary about seeking treatment themselves. So again, we're hoping that the HIT model, and we're confident that the HIT model will enable us to join up, sit together in the same room, join up some of those key players in the different areas of healthcare provision. Anorexia nervosa has a peak age of onset in the mid-teens, 15 to 17. Often it becomes a very chronic illness and lasts for many years. Bulimia nervosa a little bit later, but late teens to early 20s. So the age of the people suffering from eating disorders crosses these boundaries that we put into the healthcare provision. CAMS, child and adolescent mental health services, into adult mental health services, and also paediatrics in the medical setting into general medical settings. So that's another time when people disappear out of care, and we've had fatalities around that transition where a patient has avoided or somehow not been adequately transitioned into adult services and has disappeared and become critically ill. So how do we transition effectively as a person in their journey from young people to adult services? The philosophy is also can be very different between a CAMS service and an adult mental health service. So a child and adolescent mental health service may may work in a more sort of parent-centred, parent-directed way, where the family is worked with and the parents are empowered to help their daughter usually get on with the business of eating and restoring her weight. In adult services, we tend to not work in that way. It's not effective. We need to try to engage patients with their level of readiness to change rather than trying to sort of recruit their parents into that process, or give the responsibility to somebody else. So the philosophy of treatment may also be rather different between younger persons and adult services, and that's a transition which can feel quite alarming for parents, for instance. Then there's a geographical transition that many of our patients face, and again disappear down the crack in that one. And that's Bristol's got 40,000 students in it. Bath has got slightly less, but it's got a number of tens of thousands of students in it. Our biggest referring general practice is the University of Bristol Student Health Service, which refers 60 or 70 patients into our service each year. So that's a big transition. People will come away to university thinking, I've left my problem behind me, thank goodness, I'm making a fresh start. Often they do. We don't know about those ones, but often they don't. And all the bewilderment and the challenge and the newness of being a student away from home can really, the illness can really get its teeth in again and lead to quite sudden and critical relapses into weight loss and medical instability. And then I guess finally, and most importantly, there's a difference in aims. What are we trying to do? And I mean, like Simon described in the psychosis hit, we think it's really important that the patients, that the clients, that the people with eating disorders themselves are at the heart of what we do, because the motivations as to what would be helpful, the people's motivations, the sense of what needs to happen is very different. Many, or one might say all of the people we work with have got a degree of ambivalence about what they want, what they're ready to accept. They're probably very fearful of treatments where they feel they're going to have control removed from them. That does happen occasionally at a time of critical illness, but we'll aim to avoid that if we can. But so we're working with different people, families, patients, medical professionals, GPs, mental health professionals, who all might have a different sort of sense of what needs to happen, a different agenda of how to be helpful. And our response to that as a brand new hit is to place the PPI aspect, the patient and public involvement, is at the heart of what we're doing. We have one of our work streams is a PPI, is all about PPI, and we've had a launch of a pre-launch event, a scoping evening for PPI back in November, before we'd even made the application, which was attended by 25 people from a range of different experiences. And we used that meeting to get members of the public, eating disorder sufferers themselves, get their sense of priorities as to what we should be doing as a hit, and I'll say a bit more about that in a minute. I've talked about the health and social costs of eating disorders, which occur in young people and can last for many years. They tend not to resolve spontaneously. And so these are chronic, severe conditions which get embedded into people's lives until the lives get shaped around the illness, rather than people having choices and being able to move through life and take up increasing options as they go through. We know that there seems to be an increase in the epidemiology suggests there's an actual increase in the numbers of people with eating disorders. Patients are younger, more males, certainly an increase in uptake of services, inpatient services and community services. And that does seem to be partly due to an actual increase in clinical incidence. And we have very little evidence. There's anorexia nervosa, for instance, is a very poorly researched condition, not all that common, difficult to research. Treatments are long-term, intensive psychological treatments. So very few sort of gold standard, if you like, randomized controlled trial pieces of evidence that we can use. Now we're excited by that. It means that there's lots of questions that can be usefully addressed and answered. And in our hit, we've got some ideas as to where to go with research, and we've got one project which is ready to go, which I'll tell you about shortly. So. We have 4 work streams in our hit. We've called one of them collaboration, because we feel we need to bring together so many different aspects of players from the sort of healthcare landscape and social care landscape. And we have a commissioner, an academic and a clinician as directors. We have another work stream, as I said, which is PPI, patient and public involvement. And then our further 2 work streams are transitions, particularly looking at various different transitions of the kinds I've alluded to, and research. So those are our 4 work streams. And our broad aims are prevention and treatment, like all of the hits. And we've got various ideas for prevention, one of which is going to be commencing in September, and I'll talk about the Succeed project shortly. And we've got other ideas, research-based ideas, which are coming out of Helen Molsom's department in UE. We also have a Bristol University collaborator, Peter Rogers, from experimental psychology in Bristol. But as to encouraging ideas which we're hoping to roll out into research, and some grants possibly we're applying over the summer, and I hope we're going to be successful in getting a PhD student to look at one of those projects. And how do we treat eating disorders? Well, one of our research ideas is to really research GPs' needs. We do GP training. We've done it for years. Are we actually doing it usefully? Are GPs remembering what we say? There's an awful lot of GPs, and they turn over very rapidly. But we're going to try and go out to GP surgeries, hear what a selected sample of GPs say they want to know. We'll choose GPs who've had some involvement with our patients and where things may not have gone all that well, to see if we can really explore the training needs of GPs and that'll help us shape our training input. Okay. Now our first activity as a HIP is going to be a research meeting. We're planning to hold a 6-monthly half-day research meeting. Our first one is on the 8th of July, and it'll be at the Department of Experimental Psychology at the University of Bristol. And we're hoping to roll that out as a sort of a mini conference. We'll invite all of the stakeholders in our HIT, and we've had a couple of big scoping meetings with GPs and hospital physicians, mental health professionals, service users, voluntary sector organisations, commissioners, and local authorities, public health representatives. So we've got all of those people in the room, and we're hoping that we'll get a good representation at that initial research meeting. At that meeting, we'll discuss the different roles that the people present have, and we will hope to generate sort of further research ideas from that. And I'm going to talk about the project that's most advanced, that's come out of our collaboration. It's interesting, even just setting the HIT up and writing the application leads to collaboration, and we've found that we've got ideas already which have gone quite a long way. And the Succeed project is an intervention which was developed in the States but has been trialled in Britain on a number of sites among university-age students, and it's a psychoeducational program to try and address body image distortion, the thin ideal, which is so prevalent in our society, and it looks at different aspects, and especially challenging media stereotypes of beauty and success, and promoting cognitive dissonance. So that's trying to encourage people to actually hold different views and question their assumptions and their views. So using cognitive dissonance as a way of changing attitudes. And the project that we've got funding for, and will start in September, will take place in 5 secondary schools. It'll take place over a year, perhaps slightly less than that. And we're hoping to reach 250 people in 5 secondary schools in Bristol and in South Gloss, in groups of about 10, probably over about 4 sessions of an hour each. And we'll be looking before and after at any shift in attitude. Certainly the work's been successful in an older age group. We want to see if it's going to be effective in a sort of 16 to 18 age group. A further example of research which we're less advanced with, which has come from our PPI launch event in November, where people really identified the ending of treatments as a difficult time for them. The people with eating disorder said how hard that was. So we're hoping to do a qualitative piece of research about the experience of leaving hospital when the minority of patients get admitted to inpatient eating disorder units, and when they leave, that's a very difficult time, and maintaining the weight restoration and the psychological changes is extremely difficult. Often people backtrack and lose some of the benefits they've got. So we're going to try and do a qualitative exploration, again with a PhD funded student to lead that, as to what's going on and what where the difficulties come in, and that we hope will help us shape our services and our interventions. Thank you.